Hello everyone, my name is Mallory. The genetic disorder that I chose to present about is the congenital adrenal hyperplasia. Over the semester, it's been something super interesting to dive into as far as research is concerned, and I hope that this presentation helps you understand a little bit more about congenital adrenal hyperplasia as well. So this disease process is an autosomal recessive disease process, meaning that both genes that a human being receives must be affected with the congenital adrenal hyperplasia for it to be present as far as an affected person is concerned. So you can be a carrier of this disease and not show any symptoms and not be affected with the disease, but you have to have both of those genes in order for you to be an affected person. So it is the absence of an enzyme called the 21-hydroxylase enzyme, which is part of our hormone production. And the reason we're dealing with hormones is because where this deficiency occurs is going to be in the adrenal glands, which lie right above our kidneys. Okay, so it was first discovered and documented by Luigi Di Crescio in 1865. So that's just kind of a fun fact. There are two different types of congenital adrenal hyperplasia. The first type we're going to talk about is really the main one that we get concerned about as far as talking about this disease. So the first one we're going to talk about is going to be the salt-wasting congenital adrenal hyperplasia. So in a normal world, in a normal anatomy, a normal body, our adrenal glands are actually supposed to be able to retain a certain amount of a natural electrolyte called sodium. And if the body can't do that, it actually excretes through the urine. So that's when we get to talking about the CAH. So it is what we call a 21-hydroxylase enzyme deficiency. So again, it makes those adrenal glands unable to retain enough salt, and it excretes through the urine. And this can actually cause death, because when we're losing so much salt and unable to keep it in our body, it can cause people to go into shock, and again, it can be deathly. So it is very important for us to get a head start on having congenital adrenal hyperplasia, and I'll kind of talk a little bit more about that later on in our presentation. So there is another form that we talk about, and it's going to be the simple viralizing form, which is just the basic congenital adrenal hyperplasia. So when talking about the simple viralizing CAH, it's not necessarily as important as our salt wasting kind, because it's not going to cause death the way that the salt wasting kind can. But it is still one of the types of congenital adrenal hyperplasia that we can see. Moving into major characteristics. So there are physical characteristics that we can see when dealing with congenital adrenal hyperplasia. The first thing to note is going to be that in female newborns, we can see things called ambiguous external genitalia. Just meaning that we don't really know what we're looking at when we see it. So they don't have the normal labia, things like that a normal newborn girl would have. So with that being said, their internal organs, as far as their reproduction is concerned, are obviously our ovaries and our uterus are still going to be the same. So they're going to still be natural anatomy in that regard. Moving on to newborn males, we can also see enlarged genitalia, so enlarged testicles, enlarged penises in our newborn males, which can be indicative of having congenital adrenal hyperplasia. For our kids that have less severe cases of congenital adrenal hyperplasia, we may not catch it early, but in children 2 to 3 ages, we can start to see symptoms of having congenital adrenal hyperplasia. And what those symptoms can consist of is going to be basically going into early onset puberty. So things like hair on our pubic area, or hair on the armpits, or really well-defined muscular structure, or even sometimes, how we all get acne at puberty ages. all these things that would never normally happen at the age of 2 to 3 can potentially happen with our affected congenital adrenal hyperplasia patients. Symptoms that are not necessarily externally seen are going to be low blood pressure, and I'll kind of hit on our low blood pressure a little bit more with a chart that I have later on in our discussion. But obviously we're talking really heavily about the low sodium levels due to the salt wasting type of congenital adrenal hyperplasia. Metabolic acidosis, dehydration, and shock. Again, when we're losing so much of one thing at one time, it can send our body into shock. But we can also have things like vomiting or diarrhea that are associated with congenital adrenal hyperplasia. But again, those are also associated with things like the stomach bug. So if we're just having vomiting and diarrhea, I wouldn't say that medical professionals would be as likely to test a kid or an adult for congenital adrenal hyperplasia at that point. So moving on to the molecular cause, we are looking at chromosome number 6. Specifically in the short arm of that chromosome is where this mutation is going to occur. So this is a mutation of the CYP21A2 gene. And that mutation is what is going to cause the deficiency of the 21-hydroxylase enzyme itself. So this particular enzyme, its function is to basically produce cholesterol, produce hormones such as aldosterone and cortisol, which are the two hormones that we'll kind of hit on more specifically. Cortisol is going to maintain our blood sugar levels, and aldosterone is actually going to regulate the amount of salt retained by our kidneys. And other things that this specific enzyme can do is it can break down drugs, and it can also help produce fats. So again, found on the adrenal glands, and it is very important in our hormone production. Okay, so here is my fun little picture that I was kind of discussing earlier in the presentation. So in this picture, you can actually look, you can see our kidneys, and then you can see those nice little yellow structures that are sitting on top of it. Those are the adrenal glands. So the dashed line in this picture, any dashed line that you see is going to be something that congenital adrenal hyperplasia affects. Okay, so you can see that the dashed line that goes from the adrenal gland to aldosterone. So you have a decrease in aldosterone levels, which means you're going to have a decrease in ability to retain the amount of salt that the kidneys need to keep. Okay, so moving down, you see that it's going to increase our potassium levels. It's going to decrease our sodium levels, and it is going to decrease the low blood volume, which again will send us to the clinical sign of low blood pressure. Okay, on the other side, you can see our dashed line. It goes to decreased adrenaline. So we can decrease the adrenomedullary adrenaline secretion. Okay, and also if you look there, it's also going to decrease our cortisol levels, which just means that we're going to decrease the ability to regulate our blood sugar. Okay, and there are 2 points over here to the side that are very important in regarding to this chart, but I thought that this chart was extremely interesting in kind of explaining how our congenital adrenal hyperplasia affects the bodily function as far as our adrenal glands and the hormone production. Mode of inheritance. So I know we previously mentioned at the beginning of the presentation that it is an autosomal recessive inheritance pattern. So here is just a little picture that says, okay, hey, dad is a carrier and mom is a carrier, which means that neither one of these people are affected with congenital adrenal hyperplasia. So when they are passing this down, we have 3 children who are unaffected. Okay, one of those children has no carrier. It's not a carrier. It doesn't have the disease. So it's basically free and easy, down the road we go. Okay, the 2 middle children are carriers. So because both of their parents are carriers, one of their parents pass down a gene that is a carrier of the autosomal recessive pattern. So the CAH, we are carriers of that, but we are not affected, which just means we can still pass that carrier down. We just are not affected at that point. And then here we are, we have the single child that has the condition. So this just means that 25% or 1/4 of this particular pairing is going to have the chance of being infected with congenital adrenal hyperplasia. So here is another pedigree tree, and we've got pedigree tree A. We have an affected human and an unaffected human. So someone is always going to receive an affected gene, and someone is always going to receive an unaffected gene. So with that being said, when these two parents mate, they will have carrier children every single time. So 100% of the time, they're creating a child who is a carrier of the congenital adrenal hyperplasia and can potentially pass it down along the line. In B, we have an affected congenital adrenal hyperplasia person, and we have a carrier person. So again, the affected person is always going to pass down a gene that has the congenital adrenal hyperplasia. The carrier will 50% of the time pass down the disease, so the gene that carries the disease, and 50% of the time they're going to carry down that doesn't have the disease. So here in this pedigree tree, you can see that 50% of our offspring are going to be carriers and 50% of our offspring are going to be affected. So with that being said, this is just a small pedigree tree, nothing very invasive as far as that's concerned, but small amount of information in that regard. There are genetic tests available, and one of these particular genetic tests is actually required at our newborn screening. So the main test that is used to diagnose congenital adrenal hyperplasia is going to be the 17-hydroxyprogesterone test, which is otherwise known as the 17-OHP test. And what that is measuring is going to be the 17-hydroxyprogesterone that is in the blood. And that is a hormone that is produced, again, by the adrenal glands, which can help diagnose congenital adrenal hyperplasia. Most commonly when we're doing our newborn screening, but it can also be used in adults and children who are not as severe cases. So other testing options we have available are the DHEA sulfate test and the cortisol test, but both of these tests are not typically done unless we see that we are having an abnormal OHP result. The 17-OHP testing is required by law as a part of newborn screening regulations. So in most states, you're going to see that this test is just part of the course as far as getting our newborns tested and making sure that they do not have this disease. So it is typically done within 1 to 2 days of age. So when the mom and the baby are hanging out at the hospital for those 1 to 2 days, this is just part of what they're doing to make sure that we have a happy, healthy baby. Okay. Early detection and treatment is very important because, like I said earlier in this presentation, salt wasting congenital adrenal hyperplasia can be deathly. So if we catch this at early stages, it is critical for us to go ahead and start treatment at that point. And just a little fun tidbit, I chose this disease because I work in the veterinary field as a licensed veterinary technologist. And right now we're seeing kind of an influx in my particular clinic of a disease called Addison's disease, which both the congenital adrenal hyperplasia and the Addison's disease deal with the levels of aldosterone, which is the hormone, again, produced by the adrenal glands. So while they're not the same, they do have a lot of aspects that kind of intertwine, which I thought was a really neat way to kind of integrate human medicine and animal medicine. References that I use are listed here, so if you want to dive deeper, these are all wonderful references that I had a really good time reading, and they gave me a lot of information that has advanced my knowledge on the congenital adrenal hyperplasia.